Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. I feel like I didn't say that last time, but I pretty much always do.
No, you did. You absolutely did. Yeah.
Yeah. Well, I'm joined today, as always, by my benevolent co-host, Dr. Jason Martin.
I'm very benevolent.
He's a board-certified plastic and reconstructive surgeon. I had to think of B words today.
Yeah.
Because Dr. Martin, we're talking...
Boss. B-O-S-S.
Boss. He's my benevolent boss. You actually are.
Yeah.
So, yes.
I technically am.
Yes.
Am I?
Yes. Is.
But am I?
Yeah.
I think Nils knows the truth on that.
Well, I'm the director.
Okay. I feel like I work for you. I feel like I'm part of the federal government apparatus and you are the president.
I'm the director.
Okay.
You're the president. I'm the director.
I got it.
Yeah.
I got it.
So Dr. Jason Martin, he is a board-certified plastic and reconstructive surgeon. Dr. Martin, how are you doing?
I'm doing really good. I love this topic, by the way. Hopefully everyone watched part one. If they haven't, they should go back and watch it.
If you have stumbled upon our podcast and you are not familiar with it, you can find us on social media at Beauty and Surgeon Podcast. And we are also on YouTube at Jason Martin MD and wherever you find social media. There is a part one. So this is everything you need to know about blepharoplasty part 2. We're going to be talking a deep dive into kind of the second half we covered in the first part, what a blepharoplasty does, what it can and can't do, how to choose a surgeon, what to expect at pre-op. And then we just abruptly ended.
Yeah.
So
it was kind of traumatic. I'm a little bit emotionally
It always is when we have a part 2. I'm like, oh, shoot, we're at the end of the slide.
You built me up and then you just drug the rug out from underneath me.
Well, this is like the meat of the surgery. So we're going to talk about the surgery in detail. So what actually happens during a blepharoplasty. Again, we'll kind of go over the types of blepharoplasty, how to address those issues, talk about recovery, risks. This is a very important episode to listen to.
Yeah, I totally agree. Listen
to part 1 and then come back and we'll hear you here again on part 2. So for those of you who've already listened to part 1, we're going to just proceed with part 2.
And Amy's still going to translate with my big words. That's good. Let's go.
There are many big words in this. All right. So blepharoplasty, step by step. The basics, because we're going to talk more. We have some pictures that show the actual placement of the incisions
I feel
on
like
our next couple of slides.
Paula Abdul had a song Step by Step. Did she? I mean, there's some
No,
stuff.
that was Backstreet Boys.
Oh, Backstreet Boys.
Step
okay.
by step.
Yeah, thank you.
Oh, baby.
Yes.
Yeah, Paula Abdul was 2 steps forward, 2 steps back.
2 steps forward, 2 steps back. Mm-hmm. Yes.
Opposites attract.
Opposites attract. Okay.
Ooh. Right. I was going to say the Cheeto cheese guy.
Yeah.
Oh, man, I was actually a huge Paula Abdul fan when I was in like the 2nd grade.
Well, she could dance and sing.
I did my talent competition to Opposites Attract.
Right. I was also in 2nd grade when Paula Abdul was good.
She was on Wheel of Fortune the other day and did great.
Yeah. Really?
Did she win?
Yeah.
There's Celebrity Wheel of Fortune?
Yeah. Huh. It was really good.
Wow.
She's making a comeback on Wheel of Fortune.
There we go.
Okay. So blepharoplasty, eyelid surgery. We can't call it eyelid tuck. So can we just kind of, if you're going to have the surgery, go back and listen to step 1. You can figure out everything we need to do. It treats the upper and lower eyelids. So this is the day of surgery. First and foremost, blepharoplasties can be done both in the office or in the operating room, right? The office might be a procedure room. The operating room would be a place like a surgical facility or a hospital. That's first and foremost. And when you're thinking about surgery, you're thinking about the type of anesthesia you're going to get. So, Amy,
step 1? You got to numb it.
Yeah. So what are those types of anesthesia that exist?
There are several. If you're doing this procedure awake, you probably will just do local. So just like you would get at the dentist, we're just going to numb the area up. You may or may not have the option of doing a little bit of oral anaphylaxis, so something to maybe relax you a little bit.
Not anaphylaxis.
Oh, no.
Yeah,
You're going to have an oral reaction to this. And then we're going to stab you with an EpiPen.
It's angiolysis.
Yes.
Yeah.
Oh, I'm glad you heard me say that. Yeah,
but it's okay.
You will not have oral
No one caught that with me, but I'd loved every bit of it.
Yeah. Oh, that would be bad. Oral
so
anaphylaxis.
You're going to have local anesthesia with some sort of pill to make you relax.
Maybe, but you really don't need it with this procedure. It's so fast. By the time those types of things take effect, you're usually finished. So with or without it, you'll be fine. But either way, we will do some local to numb it. And that's whether you're awake or asleep.
Yep.
Going to the more asleep route, then you could go a step up and maybe just get a little bit of IV sedation. So like propofol if you were getting a colonoscopy or even a sleep dentistry. So when you go to a sleep dentist, that's what they're giving you. And then there's the next step up, which would be general anesthesia, which is not as scary as it sounds. So this is just a more heavy sedation, essentially. Your surgeon is going to recommend the best choice for you, and there may only be one. If you're in the office, your option is to be awake. If you're in the OR, your option is to be some level of asleep.
Right. And if we're going to be very honest, it depends on how you feel about people working around your eyes.
Some people if you're claustrophobic.
Some people do really well with it. Other people are not down with that feeling. Yeah. So you kind of have to work through that with your surgeon beforehand. If you feel like that's going to be a real problem for you, just go to the surgical facility, get some intravenous sedation. It costs more money, but it's going to be worth whatever you spend for sure.
Oh, absolutely.
Some people use Pronox or nitrous oxide. That's another thing that people use, but overall,
not as much with eyelids because it makes people chatty.
Right. Overall, you're going to get local anesthesia. That's the guarantee. And from there, it just depends on what the surgeon wants for further sedation. Okay.
Yep. So you're going to be numb and you're going to be either asleep or awake, but you'll be numb.
Okay. So this is where everything is the same now. So once you figure out, once that decision's been made, you're at the operative facility, at the office or in the procedure room, then you're going to be placed on the surgical bed, and you're going to be prepped and draped. And what that means is they put stuff on your skin to kind of sterilize it. They put some towels and some drapes around you to keep everything sterile and to keep your face covered. And we are going to use incisions with this surgery. We talked about this in part 1, but we're going to go a little more in detail here. I'm sure Amy has pictures too, which we can show you at some point. Look at there.
I do. This is the upper eyelid incision.
Yeah. So the upper eyelid incision, as we said before, goes into that supratarsal crease, which Amy said is the crease that occurs when you open your eyes. And we take out what I call a fusiform pattern of skin, which is basically, I don't even know how you call fusiform.
Like a really lazy S.
Okay. Yeah. There we go. Yeah. Whatever Amy says, you go with that.
Or like a dolphin, like a breaching dolphin.
So, and this is, the amount of skin you take out is really decided in that preoperative exam and your markings. Markings really are hugely important in eyelid surgery. This is how I teach the fellows. So, some people have a lot of skin you can take out. Some people have a little. You're going to use, if you look on the YouTube channel, if you're listening, you should stop everything you're doing and watch YouTube. All right. And like and subscribe to our channel. So if you could see that kind of pattern of skin removal, you're going to make that incision for the upper. For the lower, it's really basically, we're showing it here too. Look at Amy. This is, you're a pro.
Yeah.
You should
Sarah's a pro. She put these slides together. I sent her these pictures.
Yeah.
Yes.
So for the lower, you're going to make an incision right underneath the eyelash. And actually, this picture here doesn't really show truly what we usually do, which is go out along the crow's feet from the corner of the eye, which is called the lateral canthus.
And this incision is the same whether it's inside or outside the eye. The placement is pretty similar. Yeah. I mean, it's a little bit lower if you're on the inside of the eyelid, but it's right there, like very close to the top of that lash line either way.
Totally. On the inside of the eye, which we call transconjunctival, you make small little incisions below the eyelashes from the inside of the eye, and that's how you gain access to the fat. But anyways, it depends on if you're doing a full blepharoplasty, like the upper and lower, or only the upper, only the lower. That's really going to be the indicator of where those incisions are going to be. But it's important to know that those incisions in the upper you will not see with your eyes open, and the lower, if you have some amount of eyelashes, they're very well camouflaged.
Oh yeah.
Yeah, and even within a couple of weeks, it's hard to tell they were even there.
Sometimes within a week.
A lot of people don't like, or they get concerned about the crow's feet incision, and that's funny. If you're younger, I get it because you may not have strong crow's feet, but most people have some crow's feet there. It actually heals really well and it's barely visible.
Yep. We call that extending into the righted, into the wrinkle.
All right, so Amy, let's talk about step 3 on this.
So we're calling step 3 of the work. So what happens after we make an incision? Like we don't just make an incision and call it a day.
Why not?
So it
that would make my life easy. Yeah, close everything up.
That's orthopedic. Yeah. So you had to be an ortho to do that. Surgery jokes.
That's libel.
Yeah. So on the upper eyelids, we're taking out skin in all cases, maybe removing some of the fat pad. Maybe, and then possibly doing some muscle repair. You can do some limited muscle repair on the uppers with just that upper eyelid incision.
Yeah, and the fat pads, there's a middle or medial right next to the nose. There's a middle and there's a lateral. There's 3 or 4 different fat pads up there, but to find there's a middle and medial. And you may take out more of the inside near your nose because that's the stuff that pops out and keep the middle part there. Yeah. When Amy talks about the muscle repair, there's an orbicularis muscle, which we didn't really talk about in the first episode, which is funny. That's the circular muscle that goes around your eye. It's really important. That's what you get Botoxed. That helps with eye closing. It's a very important muscle, and you sometimes will have to go through that muscle for different things to get to fat, to resuspend that muscle in certain areas. So you may do something in the upper eyelids, most likely not. The surgery for muscle repair in the upper eyelids is usually for droopy eyelids. We're not going to have that. This is not this episode about ptosis. There's a droopy eyelid condition for older people that happens.
Like lag.
Yeah. And there's for kids too, congenital ptosis, very, very common. You see that there's specialists, oculoplastic specialists that do this surgery.
They put those little gold weights in to help pull the eyelid open. It's crazy.
There's different surgeries to do. And those are very specific, and you can do some muscle repair there. We're not going to talk about that today, but just know that exists.
Yeah. For cosmetic purposes, it's usually just skin, maybe a little bit of fat.
One other thing on the upper eyelid, which is kind of a left field kind of thing, there is something that is a gland in your upper eyelid that helps with lubrication. Amy, do you remember the name of that gland?
Well, it's not the lacrimal glands.
No, the lacrimal glands, right.
Like those are all along, though, upper and lower.
Yeah, there's a larger one on the outside, and that can droop down. Sometimes you have to tack that up to make the eyelid look better. That's an old school thing. Also, some people do brow lifts through the upper eyelid incision.
Yeah, we talked about that on our brow lift episode.
Did we?
Yeah.
All right, well, here's the brow lift episode right there. You can watch that. I don't remember that.
Yeah, we mentioned it briefly, but we to basically say that no one really does.
Well,
they
do it. They do it. It's kind of interesting. Every time I see a patient like I'm like, I think there's a change.
Right? Like, was that the right thing to do?
Yeah. Kind of. So that's the upper. Now let's talk about the lower, Amy. So the work part of it.
Yeah. So in the lower, regardless of what's happening, if we're going external, so we are definitely removing skin. If you're having an external incision along the outside of the eye,
underneath the eyelashes,
we are taking skin. So that is the purpose of that incision. Might be doing some fat deposits from there as well. And this is actually where you could do a cosmetic type of muscle repair. Like more commonly, like doing that, the little repair right there there are a lot of other, like you said, deep dive onto like eye issues that can be done through this as well. But for cosmetic purposes, you can resuspend that outer edge a little bit.
Right. I was trying to think about how to describe, when I knew we were doing this episode, the globe and the bones that surround it. And all I could come up was Sauron and his circular thing on that staff. And the thing kind of came up and held that ball in place, which no one gets that. And if I do one more Lord of the Ring reference here, you can show what that looks like in there. So like the circular ball was the eyeball, and then the bone around it is the wood that comes up and holds that in place. With that said, then you have draped over it soft tissue, skin, muscle, and a lot of really intricate anatomy. It's really complicated. So you're not touching the eyeball or even the bone for that reason. What you're really addressing is that soft tissue around it and the skin. So the idea of the circular orbicularis muscle, and I'll give Nils a picture of that, which he's going to show right now. This muscle that goes around the eye, on the outside, you're actually using that muscle to resuspend that lower eyelid up. And the idea of that is, imagine an old man with a pot belly and his pants that don't want to stay up, so they wear suspenders. That happens with your eyelid too. So taking that muscle and pulling it up into the outside, tacking that muscle up, cosmetically speaking, supports that lower eyelid and actually allows you to take the skin you need to take without that eyelid pulling down and resulting in that round, weird-eyed appearance.
Yeah, I think that's why it can sometimes look really like almost thinned out, because you have then that additional pressure from the internal structures of the eye that have started to atrophy or droop. And then the skin's pulled like too tightly over them, and it can do that weird round, thinned out look of the lower eyelids.
Right. Yeah. And another thing we do, and this gets really in the weeds, but I can explain it. I can do this, Amy. I believe in myself, my explaining skills. So one thing we do is I always do the fat first. So I'll go transconjunctival.
Which makes sense. You want to debulk it essentially.
Right, to see what I'm working with. And now there's a thing you can do when you take the fat out. You can actually transpose it over to the tear trough area.
Where it might be really hollowed out.
Yeah. Because you're taking the fat away from that herniated bulbous area and then putting the fat back in the tear trough, which is really deep, and people don't like that demarcation. And then I'll come back and I'll address the skin, and most likely I'll take some skin for people that are older. At the same time, I'll resuspend that muscle, which helps the tear trough and also supports the lower eyelid with that skin removal. But I never touch the middle of the eyelid. It's called the middle lamella. Words don't matter, but that middle lamella is that supportive area of the eyelid. And if you don't touch that, if you keep that preserved, it's very unlikely you're going to have lid distraction or weirdness to your lid afterwards in the healing process. Now, bleeding afterwards, infection, problems after surgery, swelling, you're on chronic steroids, you didn't tell us, we'll talk about that, but those can affect it. But if you do the right surgery here, it's really important. The lower eyelids are a lot more complicated than the uppers, for sure.
Far more complicated. And can go, like I mentioned in our first episode, when things go a bit wonky with the eyes, there's not always a way back from that. Because if you've taken too much skin,
You can't put it back on.
You cannot put it back.
I've heard of cases where people did skin grafts and stuff like that, which is devastating.
Yeah.
So there are cases where people have real bad problems after eyelid surgery, cosmetic ones, where you have to support that lower eyelid. And we use weird things with that. We'll actually use the roof of the mouth and use some of that tissue and transplant it in the eyelid itself. And there's other options. You can use cartilage from the ear. So there's so many different things you can do there, but
you don't want to have to do.
You don't want to have to do that.
No, you don't want to be the person who's having that done.
And one last thing I'll say on the work part for the lower eyelid is that you want to go to someone who is cognizant of these issues, who also understands safety and understands that, really good is good enough for the lower eyelid than like perfect. The idea that if you really want to pull things and get rid of it, like I do sometimes, even with facelifts, or neck lifts, like you can't do that in the lower eyelid.
Yeah, this is not a tummy tuck.
No.
This is not a pull as hard as you can.
So you want to go to a surgeon that has nuance, that understands and respects the lower eyelid and the anatomy that's there, and is always thinking about your safety first and your functionality. Because these bad things don't just look bad, your eyelid won't work as well, you get dry eyes, and that's really kind of a miserable condition. So the work is not easy sometimes.
Especially on the lowers.
By the way, I keep the eyelids, sorry to interrupt, but I keep the eyelids to the end of the case of the face and neck lifts because I want to do it when I've gotten everything done. I could just, sit down, concentrate, relax right there, and that's it. And then we're done.
Well, and a facelift can change the position slightly of the lower
totally,
eyelid.
Yes.
So, yeah, you do want to do that last. So then after all that's done, you kind of see uppers, easy. We can do it in the office. By the time you've taken anything orally, you're probably done with the procedure. Lowers should be done in a procedure with some sedation. This is not something you would want to be awake for or should be awake for.
Right.
Like this isn't a sleep procedure. And then the closure. So on the upper eyelid, we put sutures. I think it's very rare that anybody would glue that incision shut. I think all surgeons who are board certified plastic or oculoplastic surgeons are going to care about the way the scar looks. They're going to suture it with teeny tiny little sutures that come out about 5 to 7 days later. If you have just the transconjunctival incision on the lower eyelid, there are no sutures. It heals very quickly.
The incision from the inside,
Yep. On the outside, you're going to have, again, sutures. They may be what we call a rapid dissolve suture that kind of dissolves within a few days or even a week, or you would have just a little bit of suture that had to be removed a week later.
And some people on the uppers will use permanent or absorbable sutures underneath the skin. One last thing is some surgeons, oculoplastics, everybody has a little bag of tricks to make themselves feel better so they can, advertise on TikTok. Some people use lasers to take out the tissue of the skin, which is totally fine. They claim it has less swelling, and that's maybe true, but it's pretty nominal difference.
We use a Bovie. It's heat. Is it laser heat or hot heat?
Right.
It's heat. They're just using heat.
Right. Or they're using energy. That's
heat.
Let's talk about it later. So anyways,
energy.
Yeah, they're going to remove skin. Yeah. They're going to get hemostasis, and they're going to close it some way.
Yes. Yep. So we made that sound extremely complicated, which it is for the lowers, but just know you'll be numbed up. We'll make an incision. We'll do the work, whether it's taking skin, fat, muscle repair, and then we close it.
Yep.
We suture it up. Or we don't.
And if you have incisions, you probably have a little bit of tape, which we call steri strips or something like that over it.
Yeah. Like we do tape, but some doctors may not, but we do. Yeah. All right. So we're going to take a quick break, and then we're going to come back and talk all about post-op risks, recovery, all that good stuff.
Amy's expertise.
All right, we're back. So this is the part that I think everybody's actually been waiting for, even though you already heard it. Everybody wants to know about the surgery. They don't care about recovery until they're recovering.
I think a lot of people care about recovery.
Yeah, they should. But first we're going to talk, and we've hinted about a lot of these, but we're going to go into a little more detail about the risks and complications because they exist. The very first one, risks of any surgery and risks of any anesthesia are going to include things like bleeding, infection, need for additional surgery, et cetera. However, specifically with an eyelid surgery, some of these things have additional kind of complications in addition to the risk, which Dr. Martin talked about. Swelling and bruising. Swelling alone, as I cut you off in our first part when you were talking too much about swelling, like why is swelling with an eyelid procedure such a big issue?
Oh, it can affect the functionality of the eye. It can if you have dry eyes, it definitely makes it worse. It makes it uncomfortable. It's hard to sleep. And bruising in itself not only doesn't look great, but also adds to that swelling, and blood is inflammatory. Overall, this can be very uncomfortable sometimes with this type of surgery. It's not by any means super painful. Mm-mm. It's just uncomfortable.
Yeah.
Right? It's irritating.
Because you have to use, I mean, with all things in life, you need to use your eyes. So it can be very irritating. Changes in skin sensation or numbness of the eyelashes, which is something I inform our female patients about, is that when you go to put on mascara the first time, you literally will feel like you can't feel your eyelashes. It's like you're doing it.
Can you feel eyelashes?
Oh, yeah, you can. Like when you put mascara on, like, trust me, you can feel your eyelashes. Yeah.
Oh, I guess you can.
Yeah. But like right after surgery, like...
Yeah, it's like you live in a different world.
Right?
Like what is going on?
I do. I'm a woman. But that's something that I think people don't really expect, that like the hair itself will feel numb. Like you're looking at yourself in the mirror and you know you're putting mascara on, but you cannot feel it. That is something else to think about. If you're considering a blepharoplasty, you should ask your surgeon if you have fake eyelashes. You may want to talk to them about the timing of having those replaced.
Yes.
And even having them at all for surgery.
I try to preserve it all the time, but you can't preserve it all.
You can't.
The way those are put in. They're like kind of like lightly glued in. And any kind of manipulation.
So don't go in for a fill like the day before surgery, because you're going to waste a lot of money on your fill. Difficulty closing your eyes. This is something that you probably will have difficulty closing your eyes for the first few days after surgery because of swelling, which could lead to dryness. What
are those glands, Amy?
The lacrimal glands.
And what's the other ones? The meibomian?
Oh, meibomian glands.
The meibomian? Yeah.
Those are the ones that are like inside the lash line, essentially, that produce oil.
If anyone has dry eyes, they know those glands. But if you don't, then you don't know.
Your ophthalmologist probably told you to massage them, which I do faithfully.
But if you have swelling,
like I was told to do,
of your lower eyelids, and especially if you have incisions on the inside or the outside, those glands may be obstructed from the swelling. They're not going to be able to lubricate the eye itself. Yeah. So not only are you having difficulty closing your eyes, those glands are not going to be working as well. Yeah, and in addition to dryness, you can also just have like kind of constant tearing. And for the same reason, your eye is trying to kind of lubricate itself. The lacrimal glands are maybe not functioning like they should be. So your body's just producing a lot of tears. So like your eyes are dry, but you're like, look like you're crying all the time. So this first couple of days, it can be kind of a combination of a lot of things. Sensitivity to sun or bright light. Part of that is because the muscles are not able to react as quickly. So you can't the eyeball itself is adjusting, your iris knows what to do, but like your eyelids are not really helping for a few days. So you can be very sensitive to light. The eyeball's in this kind of cocoon, and when it swells up, the muscles don't move as well. You can still move your eyes, but it moves slower. Yeah, it's a little bit altered. So the really bright is going to be very shocking. Dr. Martin, this is, again, I cut you off when you started talking about this. Oh, yeah. So, well, you can have different types of bleeding around the eye. You have subconjunctival, which is in the whites of the eye. You've seen that, Oh, it's like every horror movie. Have you ever woken up with like a red eye? Oh, yeah. Yeah. Where it looks like you're bleeding inside your eye. Yeah, you look like you're possessed. Yeah. Don't forget your mic. Oh, yeah. He has a mic now. Yeah. And people say hello, Nils. Yeah.
Getting used to the mic.
Yeah. People will like freak out that after surgery, like, oh my gosh, there's blood inside my eye, because the white part of the eye is now blood red. And that is from, you can have that just spontaneously, but it can definitely happen after surgery just from like the stress or the pressure of surgery. You can also have bleeding actually around your eyeball and behind your eyeball, which is a surgical emergency. And that's what Amy was alluding to. And that's called a hematoma. A hemorrhage is this kind of bleeding into something. Yeah, like diffuses into the space and stops. The hematoma just really is defined by a pooling of blood. If that's behind your eye, it can build up the pressure behind your eye and affect the nerve, the optic nerve, which is your vision nerve. So that's a surgical emergency, and absolutely has to be taken care of in an emergency room, like right away. Yeah. You can get ectropion, which is not uncommon. Even if you do all the right things, if you listen to the work we do in the lower eyelid, and ectropion is where the eyelid kind of rolls out from the inside, kind of pushes it out, and the eyelid edge rolls over and out and down. That's called ectropion. Almost always goes away. Yeah, in competent hands. Yeah. You can have ectropion after surgery, which scares people, like, oh my God, I'm deformed and distorted. The treatment for that is ice and head elevation, FYI. And time. Lid lag is kind of the pull down part of ectropion. And you can see that even if you do all the right things and don't take out a lot of skin. It just depends on how much swelling is there. Pain is usually not that bad. It can be painful doing the lower eyelids awake, just FYI. We didn't talk too much about that. No, we said you have to be asleep for it. That's why. Yeah. And she said that another risk or complication is need for revision surgery, which is uncommon, but we've seen it. Some people just need a little more skin taken. The scar doesn't heal right. They have persistent lid lag and never came back, and you'd have to do something. We really needed to extend it out into the right and didn't, and we need to. Then they see why we wanted to, and they're like, oh yeah, do that. One thing she put on here is change in vision. People get this a lot. Like a lot of times we do your surgery, especially a transconjunctival approach or through the lower eyelid, we put eye shields in. And when I put those eye shields in, I put a lubricant
underneath the eye shield so it doesn't scratch your corneas.
Yeah, make sure your eyes really blurry.
Right. So that is like putting Vaseline in your eyes. So you wake up, you're like, oh my God, I have blurry vision, and it doesn't work. And it takes a while for your for your eyes to kind of move and work that and wash that stuff out. Unfavorable scarring.
Oh, and we did talk about this, but there is the risk of blindness. That was if you have untreated, like bleeding behind the eye, that could lead to blindness.
Yep. And by the way, I mean, there's eye conditions, glaucoma, and certain things like that, where you do certain types of injections. It could increase the pressure in the eye. So a lot of this stuff, or you take steroid drops in the eyes. So you really need to, the eyelids, you need to go to a specialist, someone who's facile with this stuff and understands not just the aesthetic presentation, but the pathology that can occur. And then scarring. I've seen a few people like this. We've been very fortunate in our practice where we really haven't had quote unquote bad scarring of the eyelids, but we've seen it. We've seen hypopigmentation or lighter color scars.
Which is really rare.
Right. Distorted scar appearance and malplacement, or the surgeon didn't put the scars in the right place. So.
Yeah. So those are, and this is something that your doctor should talk to you about. Like, some of these things are scary, right? They sound really terrifying, but going to a doctor who doesn't talk to you about these things may mean that they're not super comfortable dealing with these things. And that's not a good thing. So you should know about these risks and complications and know how to deal with them if they should occur. So what do you need to do to prepare for recovery? Again, I feel so bad because I was stopping you so much because you were talking about my support pillows and all that good stuff on this list. So
don't we have a recovery?
We do. We have a great episode on recovery.
Right there.
So number one, make sure that you read your pre and post-op or your post-op instructions and review them with your primary post-op caretaker. This is really key because that person, if they see that you're like, looks like your eye is bloody on the inside, like, are going to freak out, and like then they're going to freak you out, and their blood pressure is going to go up, and they're going to swell, and it's just going to be a whole cascade of badness. So knowing what to expect for yourself and also for the people taking care of you, that way they can be making sure that your icing is you're instructed to do, make sure you're doing all the things you should be doing when you may not be on top of it. They are as well. There's
not many surgeries that are benefited from ice application more than blepharoplasty, just so you know.
Yeah. You should know when and where your first post-op appointment will be. We do say this occasionally. We've had some really knockdown, drag-out fights from spouses who took their spouse back to the hospital the day after surgery. Yep. So know where to go for your first post-op appointment.
We've had a few of those.
Yes. If you're a patient of ours, your first post-op appointment will very likely be on video so that you don't have to drive anywhere the next day.
Amy's so smart.
Which is really nice.
Yes.
Make sure your prescription's filled prior to surgery. Definitely get your prescriptions filled. I want to say it again to everyone in the back.
Should we
get your prescriptions
filled, Amy?
Purchase any recommended post-op products, which are probably going to include things like ice packs. Definitely consider the support pillow system. I actually just someone asked this week about the link. I will send you the link. Just ask me. Put a comment in the comments below. I will send you the link to the pillow support system. It's awesome. It's like $100 on Amazon. It will help you sleep so much better. And sleep is really key for recovery because you do need to sleep at an incline. That I think if I had to choose, someone was either going to not ice or sleep flat. Which one would I pick? I'd pick no ice and sleep at an incline.
Oh, I'd go the opposite. We should try that. We should try that out. I feel bad doing that to a patient.
No, never. We can do that when you do your eyes. We'll do that for you.
No, we'll do it to you when we do your eyes.
There we go. We'll do it at the same time.
I'm not doing it. I'm icing and elevation.
Right? I would choose elevation over ice. I mean, if I had to choose, but
yeah. I wish we could split the eyelids out. I don't know how you would do that.
We just do them like 2 weeks apart.
Yeah.
This sounds terrible. This is why there's not a lot of actual scientific data on outcomes of plastic surgery.
Right.
So think about the things you use on a daily basis and move them as close to your waist height as possible, because after surgery,
you do not want to be in a dependent position. You do not want to put your head down. It will feel uncomfortable. It feels like your eyes are swollen and throbbing. And please, anyone who's had this surgery and is watching this, leave a comment and tell everyone what it felt like when you put your head down between your legs.
Yeah.
It does not feel good.
Not good. And that's the other reason why I say that plan a few days of easy to put on clothes, which means things that don't have to go over your head. So front zip, front closure, and slide on shoes for that same reason.
You can pull out your old FUBU warm-up suit.
Yeah, that's right. You wear your warm-up jackets. Oh my gosh.
90s and early 2000s.
Oh my gosh. I feel like if we were going to have merch of any kind, that's what it should be, is a warm-up suit.
Yes.
Because all of our surgeries, and it would be dark colored, for people that are like leaking all over the place after lipo. Yeah.
Anything with a toilet.
It would have pockets on the inside of the jacket so they can put their drains in them.
It would be fabulous.
I'm going to start designing the Jason Martin MD warm-up suit, tracksuit, post-op tracksuit. Oh my gosh, this is amazing. This is the best idea ever. So
like straight up like LL Cool J kind of Adidas style?
Adidas.
Or the Sopranos.
Oh, yes. Yes. Yeah. That's very good.
Oh, it comes with a gold chain.
Yeah.
To hang your drains. Okay. So anybody who's interested in that, just leave a comment below. Like, crowdsource it.
Yes.
It is normal to be excited and nervous. In fact, we expect that that's what you will be, is excited and nervous.
Yeah.
So that's very, very normal.
Be excited. And we said a lot of things can occur, but if you go to someone who's experienced, does a great job, you can expect a really good outcome. These are fairly standard procedures for people like me. The outcomes are really good and the patients are really pleased with the results.
Yeah. All right. So let's get into a little bit of a deep dive about what to expect kind of from your initial results.
I feel like this is the part where I can go get my bobblehead and I don't have to participate anymore.
You could, but it was really lonely without you here. So please don't ever leave me again. So the initial results, swelling. There will be some swelling. And Dr. Martin mentioned in our first part of this is that you should probably ask your surgeon, what you can expect as far as bruising and swelling go. Tenderness and discomfort around the eyes, some bruising. Absolutely. The fairer skinned you are, the more you will likely bruise. However, anybody can bruise. You can bruise a lot, you can bruise a little, but you should expect some bruising. Temporary numbness or changes in skin sensation. Again, you should absolutely expect this. Same thing with a little bit of a change in your vision. Like initially, you could expect it. If you don't have it, great. And then mild dry eyes. And it's a lot of times people say they feel like their eyes feel gritty. Mm-hmm. And that actually is dryness. Like people who've never had dry eyes, I think they don't understand that gritty feeling, like there's dirt inside your eyes, is dryness because your eyeball is kind of catching right on the inside of the eyelid.
One of the things that you want to avoid as a surgeon is a corneal abrasion. Mm-hmm. And those are really, really painful. That feels like you almost have glass in your eyes. That's why we do eye shields or corneal shields during surgery, especially with the lower eyelid. And even if we don't do that and the person's asleep, if they're awake, it's different because they can actually protect their eyes. They feel stuff. Mm-hmm. But if they're asleep, then we'll at the very least put like an ointment in their eye to lubricate it just in case it stays open so they don't get that grittiness afterwards. But grittiness can happen anyways. The eye is so fragile and balanced that any kind of disruption can push it into one direction or the other.
Yeah. So your first week after surgery, you've made it through the first few days. You've been icing like you were supposed to. You've been sleeping in an incline. Your bruising and swelling is starting to go away. Week 1, limited activity. I put limited because you can be up doing normal things. You just don't want to do anything that, as Dr. Martin mentioned, is going to get your heart rate up or increase your blood pressure. And that's really key with this procedure. You're going to keep your blood pressure very stable and keep your heart rate stable as well. Sleeping on your back at an incline. Pain medication, we don't typically prescribe pain medication for this procedure. We just do Tylenol. It is irritating feeling, but it's not like it's painful. Like it's just sore and uncomfortable. Uncomfortable is a good way.
Again, going to an expert that does this all the time.
Yeah. I mean, this is the
If you have a friend that did the surgery and they're like, it was the worst pain I've ever had in my entire life, I'm not really...
Pain is subjective.
I know it, but you never let me say this, but I don't see that. I don't, unless it was a big kind of surgery, resuspension of the eyelid. It was really involved, almost reconstructive.
Right. Maybe more went on than you know. Or that person just has a low pain threshold, and that's fine.
Okay.
With love and compassion.
We love.
Yeah. Natural tears.
We love them all.
Definitely just saline, natural tears. You do not want to use any of the get the red out. Absolutely not. So just natural tears. For daytime dryness, you want to keep your eyes well hydrated. And then at night, they make actually specific nighttime drops now, which are a little bit easier to use than the old school like nighttime ointment, which does still exist. Lacrolube is still on the market. But what I recommend for people now is just the Systane nighttime drops. Right. They're nice. They're really thick.
Lacrolube was like lanolin and kind of ointment-y. Yeah.
Mm-hmm. Yeah. And you squeeze it on the inside of your eyelid, essentially. Yeah. I mean, if you may need that, if you had dry eyes prior to surgery, you probably will be recommended to use that after surgery. But for most patients, I just tell them to just get the Systane nighttime drops. They're really thick, almost like a gel, and they just really help soothe the eye at night from irritation. So they're just really nice. And if you don't do any of that, that's fine too. Unlimited walking, you walk as much as you want, and you probably can return to work depending on what you do and what your social needs are. If you have sutures in your eyelids, are people going to care?
Right. If you run an Instagram channel based on your eyes, it's probably not going to work.
Oh, you've probably told your channel. Are you kidding? You're documenting every single second of it. You're working more.
That's brilliant.
Yes.
Yeah.
So, yeah. Dr. Martin, so going into weeks 2 and 3, what starts to happen?
Definitely return to work. You can drive off pain medication for 48 hours at least. Contact lenses.
Exclamation point. Dr. Martin is not contact lens wearer. He doesn't understand the exclamation point there.
Yeah, just like whatever. Contact lenses at 2 or 3 weeks, depending on the surgery. Sometimes the surgeons will delay that depending on, again, doing that lower eyelid transconjunctival approach. You're going to definitely feel much better. You can return to like a majority of basic activities. You don't want to elevate your heart rate and blood pressure even at 2 to 3 weeks because that can cause undue swelling and even increase the chance of bruising again.
Like easy weights, stuff where your head is up.
You really kind of get in back at it. By 4 weeks, you're really going to start feeling great. And it's not a super long recovery like liposuction and some of these things we do. You can gradually increase your activity. A lot of surgeons will let you start elevating the heart rate and blood pressure around 4 weeks and, work your way up to normal exercise by 6 weeks. By 7 weeks, you're actually at normal area. You can sleep any way you want.
On your side, flat on your back,
and
flat on your face.
Most importantly, Amy, what can you do at 7 weeks?
You can love your results.
Love your results.
Yes.
You spent a lot of money. Okay. You had a recovery. You were bruised. It looked like you had domestic violence on your eyes. And now you are recovered. Now you are through this hard time, and you should really enjoy your results. This is it's an amazingly transformative yet nuanced result. And I love that. It's just subtle. It's refreshing. It makes you look less tired. It makes you look a little bit younger.
You might actually feel less tired because you look less tired.
Yeah, it actually
legitimately, that's true.
Make you have better peripheral vision. I mean, it's such a wonderful, really nuanced, very specific and elegant little procedure. So
it is a good one. Yeah. So you've made it. You know everything you need to know from start to finish, from whether you're a candidate, what types of blepharoplasties exist, how to choose a surgeon, what to expect at your consultation, what to expect at pre-op, what to expect at post-op.
You could probably do the surgery yourself.
The details of the surgery. You've seen pictures.
We all know Nils can do surgery now.
Yes. So Nils has gone to the Beauty and the Surgeon podcast, School of Medicine.
Yeah.
So if
who was the guy who always
Dave? Dave. Medical school Dave. I can never remember his name. Yes. So if you have additional questions about blepharoplasty, please leave us a comment in the comments below. You can also shoot us an email a text.
Yeah.
I want texts or voicemails at 303-630-9038. My email address is in the comment box below as well, or in the description box. So if you want to send me an email, you certainly can. I love emails too. Dr. Ray, you got anything else?
No, I just love the surgery. I think it's great. Most people at a certain age are a candidate for this procedure. One thing we did not talk about, which is very important, which we do all the time with this procedure, is a brow lift.
Oh, I thought you were going to talk about something actually important.
No. Yeah.
I'm like, we missed something important? No, this is just an add-on surgery.
Yeah.
Yes.
But, I mean, it's hard to separate brow lifts from blepharoplasties. So just so you know, we do have a brow lift episode, I believe. But just so you know, that brow lifts a lot of times are combined with these procedures too. So it's good to be an informed consumer. So if you go in there and talk to your surgeon and he's like, you also need a brow lift.
Or you just need a brow lift.
Yeah, or exactly.
Yeah, that might be it.
Because sometimes brow lifts are the answer for the upper eyelids. Sometimes blepharoplasties are, and sometimes a brow lift and blepharoplasty both are the answer. It just depends on your exam.
It's quite common if you had a blepharoplasty when you were in your late 30s to early 40s, that in your 50s, you might just need a brow lift.
Yep.
So yeah, good stuff. All right, Dr. Martin. We will be back in a couple of weeks. We have a great episode coming up about why you need to be thinking about your summer body now.
Oh, I know.
Mm-hmm.
Man,
now
we need
is
to
the
start
time.
thinking about it.
Yep. And I'll tell you why.
Especially with Nils, because we've showed his picture before of him as a Viking lord.
He is a Viking lord.
Yes.
Yes. So
I got a better one. I'll post it up.
Oh, he has a new picture.
Yeah.
Nils has updated.
Yeah.
It's actually me
It's
too.
not you.
AI.
I'm looking right at you, bro.
It's AI me.
Yeah, it's as much you as it is me.
Our social media links are all in the description box and here as well. You can find us everywhere on social media at Beauty and the Surgeon Podcast and at Jason Martin MD. And we appreciate everyone for listening. Please leave us a like, a comment, a rating, review, share us with your friends, all the things. Subscribe, it's free. All right, that's all I got.
We love you guys.